Hi, I'm Rui Pereira da Costa, organizer of the Endomasters 2015. It is with great pleasure that I present to you my colleague and friend Francesc Abella from Barcelona, Spain. Francesc completed his master degree and PhD doctoral degree in endodontics at the International University of Catalonia. He has given several lectures, courses and hands-on courses worldwide, and he also works in a private practice limited to endodontics and restorative dentistry in Barcelona. His areas of special interest include, among others, cone beam computed tomography in endodontics and microcomputed tomography. Francesc is also author of several papers in peer-reviewed journals and a member of the expert committee convened by the European Society of Endodontology on the use of CBCT. And his lecture will be about, you guessed it, cone beam computed tomography. I'm sure you'll enjoy every minute. Be sure to use the comment section to send your questions or comments. See you soon.
Hi everyone, I'm Francesc Abella. Good to see you all. Before I start, I would like to thank Dr. Rui Pereira for being the inspiration and driving force behind this Congress of Endodontics and for inviting me to participate. I feel very proud to have this opportunity to share my knowledge and experience with you all. I completed my master's degree and PhD in endodontics at the International University of Catalonia. I've been working in private practices for over 10 years, specializing in endodontics and restorative dentistry. I have a particular passion for cone beam computed tomography. I'm a member of the expert committee convened by the European Society of Endodontology on the use of CBCT and an active member of the Spanish Association of Endodontics. I hope you like my presentation and enjoy a good time. So, let's begin. This presentation is cone beam computed tomography for the diagnosis of apical periodontitis, in which I will demonstrate the efficiency of this tool based on papers and some of my clinical cases. As you know, the overall objective of endodontic treatment, including initial treatment, orthograde retreatment, or microapical surgery, is to retain the treated tooth in normal function. The specific goal is to prevent or heal apical periodontitis. So firstly, we should ask ourselves what is apical periodontitis, its cause, and how can we diagnose it to adequately treat it. Apical periodontitis is defined as an infection disease primarily caused by bacteria in the root canal systems of affected teeth. Causes can be exogenous and endogenous factors as outlined in this slide. It has been demonstrated that bacteria is the main cause of pulpoperiapical pathology. This is based on classical studies, the majority carried out on animals by Kakehashi, Taggart, Sundquist, and Murar. Issues arise in the apical third of the root canal, where isthmuses, ramifications, deltas, and dentin tubules are found and sometimes unaffected by this infection procedures. It's important to differentiate between apical inflammation and apical infection. Although apical periodontitis is primarily an infection disease, bacteria isn't usually present in periapical tissues, but in the root canal system, except in certain cases of apical periodontitis associated with abscess formation, a draining sinus tract, or extraradicular endodontic infection. For example, the majority of apical periodontitis lesions with abscess formation or draining tract sinus heal satisfactorily after non-surgical root canal treatment without the need for systematic antimicrobial therapy. Have a look at this clinical case in which a diagnosis of an acute apical abscess was made in this upper premolar. In the CBCT analysis of the case, it was observed that this upper fourth premolar had 3 root canals and an apical associated lesion with the missing root canal. So, before starting the treatment, it was necessary to modify the opening axis in order to find the missing root canal highlighted in the cone beam computed tomography.
After extending the access cavity with an ultrasonic diamond-coated tip, a third canal was found with a size 10K file. On finding the canal, unfortunately, a file broke at the entry point. What did we do? We changed the ultrasonic tip for a much finer one and began working around the broken fragment. In general, my preference is to do this under a microscope, only using water every 15 to 20 seconds. Using anti-clockwise movements, we were able to remove the separate file. Here you can see the anti-clockwise movements. And finally, we were able to remove the broken file. During instrumentation, the root canals were flushed with copious amounts of 4.2% sodium hypochlorite solution. The last sodium hypochlorite solution was activated with a size 15K file under passive ultrasonic activation for 1 minute. It has been established that passive ultrasonic irrigation in combination with sodium hypochlorite is more effective than conventional hand irrigation in removing dentin debris from the root canal. Passive ultrasonic irrigation implies that it will be performed following root canal preparation, irrespective of the preparation method used, up to the size of the master apical file. In this way, the ultrasonic file can oscillate freely in the root canal, and its cutting action reduced to a minimum. When the file oscillates freely, acoustic streaming and/or cavitation is more powerful. After preparation, gutta percha cones were used to reconfirm working lengths. Finally, the root canals were filled using the System B head search. The 18 months follow-up periapical radiographs showed a continuous periodontal space with no signs of apical periodontitis. In this way, the intraradicular infections can be subdivided into 3 categories according to the time microorganisms that have entered the root canal system: primary infection, secondary infection, and persistent infection. We should take into account that primary root canal infection in an untreated root canals are a polymicrobial mix with approximately equal amounts of gram-positive and gram-negative species, dominated by obligate anaerobes. In contrast, in root-filled teeth with apical periodontitis, gram-positive microorganisms with a relative equal distribution of facultative and anaerobic species appear to dominate other microorganisms. In particular, a high prevalence of Enterococcus fecalis is frequently observed in filled root canals associated with persistent apical periodontitis. However, there are significant reasons to believe that persistent rather than secondary infection are the most common cause of post-treatment disease. In other words, contrary to the assumption that coronal leakage plays a major role in treatment failure, evidence is mounting that post-treatment disease is mostly caused by bacteria that persisted in the root canal system after the initial treatment. So, proper case selection and preoperative treatment planning are important for a good prognosis of retreatment, which is, however, 10 to 20% lower than for primary treatment. This is based on the following findings. Biopsy specimens of teeth with post-treatment disease usually reveal a bacterial infection located at the apical third of the canal, but not extending along the entire length of the canal walls, which will be suggestive of coronal leakage, that is, secondary infection. Secondly, positive culture of root canal samples taken before filling have a poor outcome. This indicates a problem of persistent infection. Thirdly, the incidence of post-treatment disease is higher in teeth with preoperative apical periodontitis than in teeth with no lesion. When coronal leakage is the most significant cause of post-treatment disease, the failure rates for the treatment of vital and necrotic teeth should be the same, but they are not. Have a look at this non-surgical retreatment carried out during a single visit. We were able to complete the retreatment and place the provisional crown. The patient didn't return to the clinic for a year, and despite the fact that they only had a provisional crown with possible coronal leakage, the apical lesion had healed. Other examples. This was tooth 26 diagnosed with chronic apical abscess. This example shows an adequate coronal restoration, but apical lesions in both mesial and distal roots. We decided to carry out retreatment and found MB2 root canal, so missing canals are responsible for the persistent intraradicular infections. We stabilized the case and focused on the 14-month checkup in which we observed a complete healing of the apical lesion. Or another case. In this case, firstly, we removed the crown and checked that the existing ferrule effect was sufficient to be able to place a new crown. We also verified that there wasn't a fracture before beginning the orthograde retreatment. Here, this example shows another missing MB2 root canal. We completed treatment in 2 sessions, and at the 4th and 8th month check, you can see the excellent appearance of the periapical tissue. But the fact that the persistent infections are the major cause of post-treatment apical periodontitis doesn't not preclude secondary infection due to coronal leakage. This is a well-considered article from Wright and Thorpe published in 1995. 1,010 endodontically treated teeth restored with a permanent restoration were evaluated independently by 2 examiners, and it was concluded that the technical quality of the coronal restoration was significantly more important than the technical quality of the endodontic treatment for apical periodontal health. In other words, a good restoration is more important than a good endodontic treatment. This article paved the way for similar studies, and these studies carry out in different populations evaluating the relation of apical periodontitis with endodontic treatment and quality of coronal restoration. They produce controversial findings. It remains unclear whether radiographic evaluation is effective when assessing coronal leakage owing to the limitation of radiographs, or whether clinical inspection of the coronal restoration is also necessary. Gomez et al. Were the first to evaluate the quality of both root fillings and coronal restoration using radiographic and clinical criteria. When the coronal restoration were scored radiographically, 78.1% were found acceptable. When the clinic and radiographic criteria for the coronal restoration were combined, the acceptable restoration were 67.4% of the total. The authors concluded that a well-sealing coronal restoration and a well-performed root canal treatment are equally important for the overall success of root canal. And more recently, Song et al. Published a similar article, giving weight once again to the importance of good endodontic treatment and a good coronal restoration for healing or prevention of apical periodontitis. From a biological point of view, we know that every infection is a race between the capabilities of the microorganisms to multiply, spread, and cause disease, and the ability of the host to control and finally eliminate the microorganisms and resulting infection. The host has physical barriers, surface epithelium, enamel, and dentin, as well as innate and adaptive immune defense to prevent pulpal and periapical infection. Hence, an infection of a tissue can manifest different histopathologic features as a result of this specific parasite-host interaction that occur. This article from Nair et al. Published in 1996 is one of my preferred. The objectives of the study were to determine the frequency of incidence of abscess, granuloma, and radicular cyst among human periapical lesions obtained for extracted teeth. 256 periapical lesions were analyzed, and 35% of these had periapical abscess, 50% periapical granulomas, and 15% periapical cysts. Under the recommended strict analysis, an accurate histopathologic diagnosis of radicular cyst is possible only through serial sectioning or step serial sectioning of the lesions, removed in toto. Periapical cysts were classified as true cyst and pocket cyst. The true cysts represent only 9% of all the periapical lesions. This implies that only 9% of those cases didn't heal after root canal treatment. Based on these results, we should ask the following. Is there a correlation between radiographic and histologic findings? As we know, radiography is designed to detect pathologic changes at tissue, not cellular levels. Even using very sensitive imaging systems such as ultrasound, CBCT, and other technologies, it's impossible to detect the presence of inflammatory cells. Furthermore, different studies carried out on cadavers, such as those of Brynolf, Green, Bartel, found evidence of inflammation in the periapical tissues of endodontically treated teeth with normal radiographic features. This finding is supported by the fact that lesions localized in the cancellous bone may not be visible radiographically unless it involves cortical bone. In addition, radiographic findings are unable to predict asymptomatic apical periodontitis granuloma from asymptomatic apical periodontitis with cyst formation radicular cyst. Accordingly, radiographic findings and histopathologic features of apical periodontitis have a poor correlation based on available case studies. This is an interesting case. I saw this patient, male 20-year-old, for the first in 2006. Tooth 21 presented itself with a significant apical lesion. I advised him that there was a risk of losing the tooth. However, taking into account the poor quality of the root canal treatment, his age, and for being an anterior tooth, the choice of treatment was orthogator treatment. The patient returned in 2007 for treatment when I was finishing my master in endodontics. Following the recommendation of my professor, at that time I placed an MTA apical plaque. Unfortunately, there was an unintentional MTA extrusion into the periapical tissue during apical barrier treatment. In many cases, nothing happens, but this may act as a mechanical irritant on palpation. So, in teeth where MTA has been extruded beyond the foramen, there should be a follow-up to monitor the outcome, which is what I did. These are the checkup images in 2008, 2010, and 2011, where we can observe a separation of the extruded MTA and the commencement of an apical healing. And in the 2014 checkup, an almost complete healing can be seen. This case is an example which demonstrated that there is no direct evidence that large cyst-like periapical lesion and radicular cyst can or cannot heal or regress after non-surgical root canal therapy. These lesions cannot be diagnosed before treatment and can only be diagnosed after surgical biopsy of the lesion. And direct clinical evidence appears to indicate that radicular cyst may be able to regress after non-surgical root canal therapy, because a high percentage of teeth with apical periodontitis heal after non-surgical endodontic therapy. In the end, his bride threatened not to marry him unless he renewed his crown. So we gave him a new crown. And these are the final clinical images of the case. At this point, the other question to be asked is there a correlation between clinical and histologic findings? Many infections or pulp inflammation are asymptomatic in more than 90% of individuals. For instance, pulp necrosis, chronic apical periodontitis, or asymptomatic irreversible pulpitis are usually asymptomatic, and patients are often surprised to find out that this infection or decay has been present for a long time. When comparing clinical and histologic diagnosis, we find that clinical diagnosis is mainly based on signs and/or symptoms, duration of disease, pulp test, percussion, palpation, and radiographic findings. In contrast, a histologic diagnosis is a morphologic and biologic descriptions of cells and extracellular matrix of diseased tissues. So, we have to be very sure that the clinical diagnosis represents only a provisional diagnosis, whereas the histologic diagnosis is definitive. As previously mentioned, similar to pulpitis, apical periodontitis is not always symptomatic or painful. This is tooth 46, which was endodontically treated 4 years ago. The patient came for a checkup and I detected a large apical lesion. Even though it was a symptomatic apical periodontitis, I decided to opt for a non-surgical retreatment. This is an initial photo of the case. The tooth was quite healthy, therefore the basic solution was to only treat endodontically. I started to remove gutta percha so that the pus could drain through the root canals. After approx 5 minutes, drainage finished and we could then complete the chemiomechanical root canal preparation in the same visit. These slides show the different imagining of endodontic retreatment and the final radiograph in which you can see an excess of root filling material in the periapical tissues. Normally, we wouldn't worry too much about this. Moreover, some professionals prefer this when there has been a good apical stock preparation. The only thing that could happen is an excess of material could delay but not prevent periapical wound healing. Notice the good appearance of periapical tissue in the 24-month checkup. Although many inflammatory mediators, pro-inflammatory cytokines and neuropeptides are capable of sensitizing and activating nociceptive sensory nerve fibers, other mediators such as endogenous opioids and somatostatin are able to inhibit firing of these fibers. The complexity of these findings support the clinical observation that there is inadequate correlation between clinical symptoms and histopathologic findings of apical periodontitis. Working on these lines, we like to use a clinical classification of pulpal and periapical disease. Based on this, we use the following terminology: normal apical tissues, symptomatic apical periodontitis, asymptomatic apical periodontitis, acute apical abscess, chronic apical abscess. Focusing on this and taking into consideration our struggle is with apical periodontitis, we should keep in mind that despite widespread use, periapical images yield limited information. Conventional images compress three-dimensional anatomies into a two-dimensional image or shadow graph, greatly limiting diagnostic performance. For example, focusing on the image on the top right, it's difficult to detect that the maxillary first molar had a total of 5 root canals. In attempt to overcome the limitation of a standard radiography, additional exposures with 10 or 15 degree changes in origin tube head angulation parallax principle may be considered. However, it should be noted that multiple intraoral radiographs do not guarantee the identification of all relevant anatomy or disease and may not reveal much more than a single exposure. This paper we published in the International Endodontic Journal. In CBCT provided more accurate information in terms of radix entomolaris inclination and root canal curvature before commencing successful root canal treatment. The following slides show a 2-year post-treatment checkup. Ideally, radiographs should be taken with a paralleling technique rather than the bisecting technique, as it produces more geometrically accurate images. Unfortunately, this is not always possible, as overangulated or underangulated radiographs may reduce or increase respectively the radiographic root length of the tooth under investigation, and increase or decrease the size or even result in the disappearance of periapical lesion. A third limiting factor is anatomic noise. Anatomical feature may obscure the area of focus, resulting in difficulty in interpreting radiographic images. The more complex the anatomical noise, the greater the reduction in contrast within the area of focus, resulting in an image difficult to interpret. Several studies have concluded that periapical lesions, which are confined to the cancellous bone, are not easily seen on radiographs. The area of focus, being masked by denser overlying cortical plate, is a further example of anatomical noise. Periapical lesion may be successfully detected when confined to cancellous bone, provided the cortical bone is thin and the anatomical noise minimal. Such lesions may go undetected beneath a thicker cortex. Here we have a case of irreversible pulpitis with symptomatic apical periodontitis in which an apical lesion is undetectable. However, when I studied the CBCT, I detect a periapical lesion associated with the apical portion of the distal root. A periapical lesion is defined as a periapical radiolucency in connection with the apical part of a root exceeding at least twice the width of the periodontal ligament. So, as you will discover later, there is a considerable amount of evidence highlighting the increased accuracy of CBCT compared with periapical radiographs. In the late 1990s, combing technology was adapted for dental application by Arai et al. And Mosso et al. CBCT differs from computed tomography imaging in that the entire three-dimensional volume of data is acquired in a single sweep of the scanner, with a simple direct relationship between the sensor and source, which rotates synchronously around the patient's head. Depending on the CBCT scanner used, the X-ray source and the detector rotate between 180 and 360 around the patient's head. The X-ray beam is cone-shaped, hence the name of this technique, and captures a cylindrical or spherical volume of data described as the field of view. Tomographic slides as thin as 1 voxel thick may be displayed in a number of different ways. Typically, images are displayed in the three orthogonal planes, axial, sagittal, and coronal. The size of the field of view is variable. Large volume CBCT scanners are capable of capturing the entire maxillofacial skeleton. Some CBCT scanners also allow the height of the cylindrical field of view to be adjusted to capture only the maxillar or mandible. This has the advantage of reducing the patient radiation dose. Limited volume CBCT scanners can capture a 40 mm high by 40 mm diameter volume of data, which is similar in overall height and width to a periapical radiograph. Interestingly, CBCT scan times are typically 10 to 40 seconds long, depending on the scanner used and the exposure parameters selected. The X-ray beam is pulsed. Therefore, the actual exposure time is only a fraction of this, 2 or 5 seconds. This contrasts with the continuous exposure of conventional tomography and affords the major advantage over CT scanners of substantially reduced radiation exposure. You will be interested to know that a CBCT has an effective dose of between 20 and 400 microsieverts, compared to a computed tomography which is between 1200 and 1500. However, as you know, it's essential with any imaging technique to keep the radiation dose be kept as low as possible. Taking this further, we're going to see some application of this technology in a typical working day at the clinic. If you are really interested in this subject, take note of the article reference which we published in January of this year. Standard practice is to have a CBCT behavior before carrying out apical surgery. This patient was referred to me for apical surgery. Previously, 2 non-surgical retreatments had been carried out, but the pain continued. In these different CBCT images, you can see the size of the apical lesion and that the buccal and palatal plates haven't been perforated. In other words, prior to surgery, I knew what to expect and what I had to do. My normal practice is to carry out a submarginal incision in anterior teeth to avoid gingival recessions. In this case, following the apical lesion removal, I did a 3 mm apical resection and ultrasonic root end preparation also of 3 mm and placed white MT8 as root end filling material. Normally in cases such as this, it is unnecessary to use bone graft material. In this particular case, I used collagen reabsorbable membrane based on findings by Archie et al. Journal of Endodontics, which state that this is the key factor to the enhanced tissue regeneration and not the grafted biomaterial. I'm pleased to say that the 5-month checkup, the apical lesion had begun to heal. My recommendation is that all apical surgery is done using a microscope. Under these conditions, the probability of success for endodontic microsurgery is 1.58 times higher than the probability of success of traditional root end surgery. A further referred case shows an apical transportation and a broken file, for which I decided on a surgical approach. Using CBCT imaging, I planned my course of treatment. Please note the apical lesion surrounding the root end and the incorrect canal shape, which luckily hadn't been perforated. Furthermore, prior to surgery, I knew that I had to make a small osteotomy as the lesion hadn't perforated the buccal plate. Let's view the microapical surgery in action. First, I made a submarginal incision and a full thickness mucoperiostal flap was reflected. I removed the entire apical lesion and after I used the 3 mm rule. In other words, this was a root end resection in which the broken file was removed and a root end preparation of 3 mm enabled me to fill with white MT8. No guided tissue regeneration technique was used, and here you can witness an effective healing of the apical tissue. Despite the fact that the trend is to use guided tissue regeneration in periapical surgery, scientific evidence suggests that the benefits of regeneration are limited in the overall outcome. Up until now, the only clear benefit demonstrated in the regeneration of periapical tissues is in the case of apical marginal bone defects or in large periapical lesions connected with the alveolar crest. In other words, when there is a complete bone loss of the buccal plate. This is a case which presented at the clinic of a woman who explained that she had detected a lump inflamed 4 months previously. The patient had a breach between 11 and 12. These initial images show a large apical lesion around tooth 12. Even though I didn't like the breach, it was adequate and without coronal leakage. Tooth 13 responded normally to the sensitivity cold test. We also did a CBCT to see how far the lesion had spread. In these images we can see that the lesion was very large and had perforated both cortical plates. Therefore, I diagnosed a through-and-through lesion. According to the more recently studied, such as Song et al., one of the negative factors that affect the outcome of the apical surgery is the diagnosis of through-and-through lesion type. In this article, all of teeth with a through-and-through lesion or complete loss of the buccal bone plate were included in order to confirm the effect on the healing outcome. The authors conclude that a favorable prognosis can be expected when teeth are covered with a buccal bone plate that is superior than 3 mm in height, regardless of the amount of marginal bone. However, it's important to note that the additional regenerative techniques were not performed in all cases in this article. Returning to the case, I carried out a submarginal incision and I could immediately see the apical lesion. I very carefully removed the entire lesion. It's advisable to send all tissue removed for a biopsy. The results in this case were of a true cyst. After removal of the lesion, I was able to confirm that the palatal bone plate was perforated. I performed a root end resection and under a micromirror I detected inadequate root end filling. Later, root end preparation and filling with biodentin was carried out. Before suturing, I did a guided bone regeneration with a xenograph and a collagenous resorbable membrane. And here is the final image. Now the patient is asymptomatic and I would surely change the old bridge for a new one. It is not a coincidence that the majority of apical surgery cases are on anterior teeth. Look at this article of Humonen and Ostarbich published in the Clinical Oral Investigation, in which the findings said that among different tooth types, maxillary lateral incisor had the poorest healing rate. For this reason, it's not unusual to find endodontic filers in these types of teeth. In our publication at the end of the last year, another interesting point is the usage of CBCT in the evaluation of root canal anatomy. However, it should only be reserved for cases where root canal anatomy cannot be fully appreciated with existing aids, such as parallax radiographs and the dental operating microscope. For example, As previously seen, the most significant variant in mandibular first molar teeth is the occurrence of a supernumerary distolingual root termed radix entomolaris. The best methods to identify distolingual roots are a 25 mesial parallax periapical radiograph or CBCT. We have to tread very carefully when dealing with anatomical variation. The frequency of distolingual roots was 14%, and a positive correlation existed between the prevalence of this anatomical variation and ethnicity directly related to the geographical location of a specific population. In races of Mongolite origin, Chinese, Taiwanese, Korean, Inuits, and Native American Indians, extradistolingual roots in mandibular first molar are considered a normal morphologic variant. A further anatomical variant which may not show up in periapical radiographs is radix paramolaris, which is an additional root at the mesiovocal site. Now let's turn to a case of Luis Contreras, a student of Master of Endodontics. His patient complained of pain in the area of 37. An apical lesion in the mesial root and a radiolucent image in the middle third of the same root were detected. To be sure that there wasn't a root perforation or absorption, it was decided to carry out a CBCT, which showed that it really was an extra root in the mesial side, so it was diagnosed as a radix paramolaris. Also note that in the three roots there was an apical lesion in each. By using CBCT as a guide, the axis was modified and the extra root canal found. The images show the status after treatment. It would have been difficult to achieve the result without the help of CBCT and the microscope. Here is a case of a friend of mine, Ivan Garrido. Have a look at this mandible canine that radiographically show an unfolding of enamel and dentin which extend deep into the pulp cavity and even reached the root apex. Dens invaginatus was diagnosed. Although the tooth responded normally to sensitivity test, an apical lesion was observed. Therefore, the diagnosis was chronic apical periodontitis of tooth 43 with an infected dens invaginatus, Ollers type 3 invagination, and surrounding vital pulp. With the consent of the patient, a small volume CBCT scan was taken of the area of interest. These CBCT axial images showed that the invagination was separated from a circular vital root canal and that this root canal space had a separate portal of exit. So it was decided to treat only the invagination. The root canal around the invagination with a vital pulp was to be left untreated. An access was made through the lingual pit of the crown into the enamel invagination using a diamond round bore and ultrasonic instrument. The necrotic contents of the tract were removed by chemomechanical preparation and then filled with gutta percha. So the pulp surrounding the invagination was not adversely affected by the infected dens and remained vital. The reconstruction shown in the CBCT images demonstrated no apparent connection between the root canal space and the invagination. This finding led us to avoid entering the root canal space. Non-surgical management of only the invagination preserved the pulp vitality and resulted in a good resolution of the periapical radiolucency at 5 months. CBCT technology can also help us in the management of calcified canal cases. This patient presented at the clinic complaining of weeks of pain in the maxillary canine area. As you can see, the canine had a yellow discoloration and was totally calcified. No apical lesion was detected, but the patient complained of pain in both percussion and palpation. Owing to the root canal calcification, a CBCT was necessary to plan the most effective treatment. Here you can see the significant calcification at the coronal level, but in the apical portion, root canal is visible. Furthermore, a small apical lesion can be seen which wasn't detected in the periapical radiograph. This goes to show that by using microscope, the decision to treat the root canal was made easier. Location and penetration of the canal orifice are often difficult and time-consuming in calcified canals. We tried to find the root canal without success, so I stopped at this point. The periapical radiograph didn't show a deviation, but there was no way to find the root canal. This could mean that the deviation was in the buccopalatal direction. For this reason, we decided to do an intraoperative CBCT which showed that the root canal at buccal level. To solve this problem, it was simply the case of moving the ultrasonic tip 2 mm toward buccal side, and by doing this we detected the root canal. I completed the endodontic treatment and later placed a resin-based sealer and a mixture of sodium perborate and distilled water that sealed the palm chamber. After 1 month treatment, this is the result. Here is our further case. Through an initial periapical radiograph, an abnormality anatomy was detected. A CBCT showed a C-shaped canal system. With this knowledge, I modified my instrumentation, my irrigation, and filling to be able to achieve the result that you will see in the image.
He kissed the girls and made them cry, those hard-faced queens of misadventure. God knows what is hiding in those weak and sunken lines, fiery thrones of muted angels giving love.
This is more evidence that demonstrates that CBCT technology offers many benefits in the diagnosis and management of root resorption and in dental trauma evaluation. We're going to see a case of 22-year-old boy who had suffered a trauma. Crown root fractures in teeth 13, 11, and 21 could be seen on a panoramic radiograph. In addition, uncomplicated crown fractures in teeth 12 and 22. In a nutshell, let's run through this case. This image showed an intrusion of 11 and remaining teeth in the 21 area. And this one, the crown root fracture of 13 with pulp exposure. During an emergency visit, I sealed the dentin of the maxillary lateral incisors and carried out the endodontic treatment of tooth 13 after removing the palatal fragment. I recommend taking a series of periapical and occlusal radiograph images to help with the diagnosis of traumatic dental injuries. The CBCT clearly showed the inexistence of an associative fracture with the exception of tooth 12, in which horizontal fracture on the apical third was detected. Therefore, firstly, we extracted both 11 and 21, in addition to a guided bone regeneration with bovine-derived xenograft in combination with a collagen membrane. Teeth 11 and 21 are seen here, and here is the appearance after 7 days of the regeneration. The patient complained a lot of pain in the 2 maxillary lateral incisors. Pain was felt in tooth 12 on percussion and didn't respond to a sensitivity test, and tooth 22 presented a symptomatic irreversible pulpitis. For this reason, endodontic treatment was needed for both 22 and 12. Tooth 12 presented with pulp necrosis only of the coronal fragment. Therefore, endodontic treatment was only necessary up to the horizontal fracture. We filled this part with white MT8. Numerous case reports, ex vivo and clinical studies have investigated the ability of CBCT to diagnose vertical root fractures. However, results are poor and inconclusive. The most common signs and symptoms of vertical root fracture described in the literature are deep osseous defects, especially on the buccal aspect of the susceptible teeth and roots, and highly located sinus tract. The sinus tract in the gingiva, especially when it is coronally located closer to the gingival margin, is also a typical sign for the diagnosis of vertical root fracture. On the other hand, the most frequent radiographic feature of vertical root fracture are the halo appearance, which is confined periapical and perilateral radiolucency. With this in mind, none of these characteristics ensure or verify the presence of vertical root fracture. Currently, Tessis et al. Suggest that only surgical flap, the identification following a tooth extraction or discernible separation of segments are acceptable when confirming a vertical root fracture. The presence of a crack in the open axis that crosses all of the tooth at the entry of the root canal can also be added to this. This maxillary fifth molar had an apical lesion associated with a mesial root. The restoration was firstly removed and the floor of the pulp chamber evaluated. After using methylene blue, the crack was more evident and the only treatment possible was the tooth extraction. In this case, following 2 years of initial endodontic treatment, this patient presented with a sinus tract. Due to the location of the sinus tract, I suspected a vertical root fracture, so a small surgical flap was decided as the treatment option. A vertical root fracture in the lingual aspect of the tooth was confirmed. Currently, cone-beam computed tomography cannot be recommended for the diagnosis of vertical root fracture. More clinical studies are required to quantify and assess the value of CBCT in diagnosis root fractures, especially in root fillet teeth and with a proper control group. CBCT can be very useful in cases where no endodontic treatment has been done, such as this mandibular molar. The tooth was necrotic and no cause detected in the periapical radiograph. So, once again, a CBCT was necessary, which subsequently demonstrate various cracks or fractures. CBCT is also a very useful tool for the detection of vertical root fracture, but its accuracy depends on the CBCT device used, exposure parameters, detector sensitivity, and voxel size. The behavioral literature support the use of CBCT as a diagnostic tool to assess the true nature of teeth diagnosed with root resorption to improve diagnosis and aid management. This should ultimately improve the prognosis of teeth with root resorption that require endodontic management. As I have tried to show you in this presentation, conventional radiographic imaging is not sufficiently sensitive to provide us with all the necessary information needed to detect the different periapical lesion conditions. We should ask ourselves, what diagnostic value does periapical radiograph and CBCT offer in the detection of periapical lesions? In vitro studies of simulated periapical lesions have confirmed the superiority of diagnosis of using CBCT over periapical radiograph. Lien et al. Concluded that CBCT was more accurate than periapical radiographs in the identification of periapical lesions associated with mandibular teeth. In their study, a 100 accuracy, true positive and true negatives of CBCT was proven. Furthermore, in vivo studies in dogs by Paula Silva, it was concluded that CBCT scan was more sensitive in detecting apical periodontitis compared with periapical radiograph, which was more likely to miss apical periodontitis when it was still present. Another interesting result was the negative predictive value. The negative predictive value for periapical radiograph diagnosis was 0.25 in this study. Thus, when an intact periradicular region was diagnosed by periapical radiographs, 75% of the cases actually had apical periodontitis. However, most of the previous studies focused only on teeth with failed root canal treatments, and no specific information about diagnosis was made. In line with these findings, our group carried out investigation taking into account the diagnosis of the status of the pulp. In the first, we compared the prevalence of apical periodontitis on individual roots of teeth with irreversible pulpitis viewed with periapical radiographs and CBCT images. The findings of the investigation showed that the CBCT images presented a high accuracy for the detection of radiographic signs of apical periodontitis in teeth with symptomatic irreversible pulpitis. CBCT scans detected apical periodontitis lesions in 20.3% pairs of roots with symptomatic irreversible pulpitis, compared with 2.4% by periapical radiographs. In the second study, we compared the prevalence of periapical radiolucencies associated with individual roots of non-vital endodontically untreated teeth, when viewed also with periapical radiographs and CBCT. In teeth diagnosed with pulp necrosis with normal apical tissue, symptomatic apical periodontitis, or acute apical abscess, CBCT images revealed a significantly larger number of radiolucencies than were revealed by periapical radiographs. In total, we conclude that CBCT detected 18.8% more periapical radiolucencies than digital periapical radiographs in endodontically untreated teeth with non-vital pulp. However, CBCT technology is not the cure-all. It also has some drawbacks such as cost, lack of clinical documentation on the diagnostic accuracy, and a potentially higher radiation dose depending on the equipment and the field of view in use. What's more, metal restorations, metal post, and root fillings, and to some extent adjacent dental implants typically cause artifacts to the reconstructed images. The potentially damaging impact this may have on reconstructed images should be considered before taking a CBCT scan. This is a case of an 18-year-old male who came to emergency complaining of an acute apical abscess. The patient was in a lot of pain, so we began non-surgical retrievement. Upon making the access cavity, the tooth began draining pus. The pus did not stop flowing during the visit, so we told him to return for another appointment. At the next visit, the tooth continued to drain. This led us to conclude that it could be a type of reabsorption. We decided to take a CBCT. These are the resulting axial slices, but we were unable to identify the problem. The other slices did not clarify the problem either. We didn't know if it was a reabsorption, a perforation, or a fracture. Because we weren't sure, we did a surgical flap. The surgical flap showed no anomaly, so we decided to perform microapical surgery. Taking advantage of the flap, we sealed the last 3 mm of the root end with MTA. Later, in a subsequent visit, we finished the treatment as if it was a conventional ortho-weight retreatment. This is what we saw through the microscope, the MTA placed in the 2 root canals. So, we backfilled the coronal and middle third of the roots with gutta-percha and sealer. Now observe, this is the follow-up at 8 months. The apical lesion has completely healed. Therefore, there are certain cases where we should bypass the established protocols and carry out other types of treatment if it is biologically possible. Here I conclude my presentation. I hope you have enjoyed it. This should show you that it's important to focus on saving teeth. Thank you for your time. Kind regards.